This training DVD has been developed for clinical staff to complement a variety of resuscitation training methods. All staff planning to attend a face-to-face training session should be familiar with the procedures and skills demonstrated in this DVD. All staff will be expected to demonstrate these skills proficiently and will be assessed when they attend for training. The Resuscitation Council recommends a 4-stage teaching strategy for clinical skills. Stage 1, demonstration of the procedure performed at real speed. Stage 2, repeat demonstration with dialogue providing rationale for actions. Stage 3, repeat demonstration guided by one of the learners. Stage 4, repeat demonstration by the learner and practice of the skill by all learners. The first 2 stages of this teaching method will be demonstrated by the DVD. That is a real-time demonstration followed by a demonstration with commentary. Stages 3 and 4 will be addressed during your face-to-face training session. You will be required to participate and be assessed in practical scenarios during your face-to-face training session. All of the skills will already have been demonstrated in the DVD. These guidelines are aimed primarily at healthcare professionals who are first to respond to an in-hospital cardiac arrest, and may also be applicable to healthcare professionals in other clinical settings. For all in-hospital cardiac arrests, ensure that cardiorespiratory arrest is recognised immediately, help is summoned using 2222, CPR is started immediately, and if indicated, defibrillation attempted as rapidly as possible and certainly within 3 minutes.
Mrs. Smith, that was your husband in the phone. He was just asking if there was anything you wanted up. Mrs. Smith. Mrs. Smith, are you okay? Can I get a hand in here, guys?
Diane, you alright?
No, she's unconscious. Can you get the trolley, Julie? Julie, can you put a 2222 call out? 4E for Edward.
That's a 2222 call out, okay? Keep the pads on, Julie. Ryan, I'm just going to move the bed, alright?
He's come in to tell her that her husband had phoned and he's found her collapsed. No signs of life. Wee lady that came through here last night. Alright. She's apparently been fine, but I'm just going to move this because of the chairs.
Okay, I'm just plugging these pads in. Okay, stand clear. Okay, it's analysing. Stay clear.
Hold on, let's get this open going.
Thanks.
Shock advised.
Okay, shock's advised. Remain clear. Oxygen's away. All clear. Shocking. Okay, straight back to chest compressions. Don't try to when you're tired and I'm taking over. Right,
If needed, press pause and forward.
One, two. Diane, I'll set a paper of serums with pillow for you and I'll take over from you. You've got them all. Did somebody call out?
2222's going out, aye.
I see, we're in and out of the room, so I don't think she's been down for any time. I done her obs about an hour ago and she got using it 0.
Right.
She wasn't feeling any pain, so it's been obviously sudden.
28, 29, 30.
She was a hypoxic because she's oxygen was in the lower morning.
28, 29, 30.
She seems fine with that.
She was up and just helped her with a wash this morning.
Right.
You're okay. So get started. Right.
30. You alright, Johnny, now? Right. 30. Almost there, Johnny. Almost at 2 minutes. Great. 2.
Press analyze.
Okay, analyzing, stand clear.
Do not touch patient.
You better take over, Julie. Okay. Remain clear.
Shock advised.
Okay, shocks advised, oxygen's away. Clear.
Stand clear.
Okay, shocking.
Press shock delivered.
Hi there, how are you? I'm only coming in by one. What's the story?
This is Jessie Smith, she's a 65-year-old lady, come through from Cormacare just last night. She'd stayed and done it here Myers for an MRI. She's been well, she was up this morning, I've been in and out the room, but I just came in routinely and found her unconscious, not breathing. She's had 2 shocks, this is just into the next 2 minutes of CPR. She's got no access.
Right.
You get a bed for him on today? Maybe get the drugs out, get them ready as well.
I'll do
Maybe
that.
go to the area there then.
Maybe seems fine, her chest rising well enough.
We'll keep going for 2 minutes. So she's had 2 shots there.
She's had 2 shocks, yeah.
First, ensure personal safety. When a healthcare professional sees a patient collapse or finds a patient apparently unconscious, they should assess if the patient is responsive by gently shaking his shoulders and asking loudly, "Are you all right?"
Mrs. Smith, that was your husband on the phone. He's asking if you want anything in at visiting. Mrs. Smith. Mrs. Smith, are you all right?
If the patient does not respond, shout for help.
Can I get a hand in here, please?
Ask any assistance to bring the emergency trolley. Turn the patient onto his back if necessary. Open the airway using head tilt and chin lift. Keeping the airway open, look, listen and feel to determine if the victim is breathing normally. Listen at the victim's mouth for breath sounds, look for chest movement and feel for air on your cheek. This should take less than 10 seconds. Agonal breathing, occasional gasps, slow, laboured or noisy breathing is common immediately after cardiac arrest and is not normal breathing. It is a sign of cardiac arrest and should not be mistaken for a sign of life. If you suspect that there is a cervical spine injury, try to open the airway using a jaw thrust. However, efforts to protect the cervical spine must not jeopardise oxygenation and ventilation. Those experienced in clinical assessment may wish to assess the carotid pulse. This should be performed simultaneously whilst checking for breathing. As soon as cardiac arrest has been confirmed, one person must start CPR and ask another member of staff to call the cardiac arrest team.
Julie, can you go and put a 2222 call out 4E for Edwards,
Right.
cardiac arrest?
The cardiac arrest team should be summoned by dialling 2222. Dial 2222, wait for the operator to answer.
Hospital. Cardiac arrest, 4E for Echo, Crosshouse Hospital.
Clearly state cardiac arrest, your location and the hospital from which you are calling. Await confirmation from switchboard operator. Do not hang up until you are certain that the operator has the necessary information.
You have that information? Thank you, bye.
One person starts CPR as others call the resuscitation team and collect the resuscitation equipment with the defibrillator. If only one member of staff is present, this will mean leaving the patient. The correct hand position for chest compressions is the centre of the chest. The recommended depth of compression is at least 5 to 6 centimetres. The rate is at least 100 compressions per minute, but not more than 120 per minute. Allow the chest to completely recoil in between each chest compression. Minimise interruptions and ensure high quality chest compressions. The person providing chest compression should change about every 2 minutes or earlier if unable to continue high quality chest compressions. This change should be done with minimal interruption to compressions. When the defibrillator arrives, switch on the automated external defibrillator machine and follow the AED's audio-visual prompts. Apply self-adhesive defibrillation pads to the patient. These should be applied whilst chest compressions are ongoing. Place one AED pad to the right of the sternum below the clavicle. Place the other pad in the left mid-axillary line, approximately over the position of the V6 ECG electrode. It is important that this pad is placed sufficiently laterally and that it is clear of any breast tissue. Care should be taken to ensure that there is no air trap between skin and pad, and the pad is in contact with skin only. The pad should not come into contact with any metal, for example ECG electrodes, jewellery or zips. Care should be taken to ensure that the pads do not come into contact with any water. Although most AED pads are labelled left and right, or carry a picture of their correct placement, it does not matter if their positions are reversed. If this happens in error, the pads should not be removed and replaced because this wastes time, and they may not adhere adequately when reattached. The victim's chest must be sufficiently exposed to enable correct pad placement. Chest hair will prevent the pads adhering to the skin and will interfere with electrical contact. Shave the chest only if the hair is excessive, and even then spend as little time as possible on this. Do not delay defibrillation if a razor is not immediately available. Ensure that the defib pads connector is plugged in fully to the defibrillator. Once the pads have been connected, the machine will start to analyse the rhythm.
Analyzing. Do not touch patient.
Ensure that nobody touches the victim while the AED is analysing the rhythm.
Advised.
Okay, shocks advised, remain clear.
If a shock is indicated, ensure that nobody touches the victim. Push the shock button as directed. Immediately resume CPR using a ratio of 30 compressions to 2 rescue breaths. Remove any oxygen mask and place it at least 1 metre away from the patient's chest during defibrillation. If no shock is indicated, immediately resume CPR using a ratio of 30 compressions to 2 rescue breaths. Continue as directed by the voice or visual prompts. Minimise as far as possible any interruptions to chest compressions. The quality of chest compressions during in-hospital CPR is frequently suboptimal. The importance of uninterrupted chest compressions cannot be overemphasised. Even short interruptions to chest compressions are disastrous for outcome, and every effort must be made to ensure that effective chest compressions is maintained throughout the resuscitation attempt. The person providing chest compression should change about every 2 minutes, or earlier if unable to continue high quality chest compressions. This change should be done with minimal interruptions to chest compressions. As soon as equipment and sufficient staff are available, the airway should be managed optimally. Maintain the airway using head tilt, chin lift and jaw thrust. These simple positional methods are successful in most cases where obstruction is caused by loss of muscle tone in the pharynx. If spinal injury is suspected, maintain the head, neck, chest and lumbar region in the neutral position during resuscitation. Provide artificial ventilation in any patient in whom spontaneous ventilation is inadequate or absent. This normally requires 2 people. One person holds the face mask in place using head tilt, chin lift and jaw thrust. An additional person should then squeeze the bag gently to deliver ventilation. Deliver each breath over approximately 1 second and give a volume that corresponds to normal chest movement. This represents a compromise between giving an adequate volume and minimising the risk of gastric inflation. The airway may be supplemented using an oropharyngeal airway. An appropriate sized airway should be used. Measure the oropharyngeal airway from the angle of the jaw to the upper incisors. With the mouth open, put the airway in upside down before rotating it 180 degrees. After 2 minutes of CPR, follow the AED's audio-visual prompts. Plan what to do if the rhythm is shockable before CPR is stopped. Safety issues should also be addressed and planned for while chest compressions are ongoing. To summarise, it is imperative that cardiac arrest is recognised and confirmed quickly. Resuscitation equipment should be summoned expediently and the cardiac arrest team alerted via 2222. Effective CPR should be initiated immediately. Use the AED to assess the cardiac rhythm quickly. Early defibrillation using the AED, supported by good quality CPR, will improve outcomes. Use S-bar communication to update the cardiac arrest team when they arrive.